get started for today. Thank you all for joining, and we hope today will be very helpful to you. I want to thank Autumn Daniels for assisting with the webinar today. Autumn's with the Indiana Rural Health Association, and they help support Zoom, which Zoom's been a bit of a challenge recently with all of the changes that they have done to their product. So kind of bear with us if we have some of those challenges today. Also, a big thank you to Joyce Fillenworth and David Conrad for working so hard at the State Office of Rural Health and helping cover the COVID helpline. They have put in numerous hours there. And just a reminder, an invitation was sent out to the regional meetings that we had to cancel in March. We're going to do that virtually, so we will have it no matter what happens. Even if we open back up, we're still going to continue virtually. Of course, in June, we won't be completely open back up, but just for clarification, we will have the virtual sessions from 8:30 to 12:30. We have it broken up into smaller groups, so we want the sessions to be very informal, and really feel free at any time to ask any questions and open up your lines and talk and communicate with one another. There is no registration, and you invite anyone internally you like to attend. We had put on the agenda which topics would be most appropriate for which staff members to be there. It's not necessary for all staff members to be there for the full time from 8:30 to 12:30. And again, just invite anyone that you think would benefit from the information or have questions. The presentation was sent out today about 11:30 along with some additional handouts. And I'm Becky Royer. I am subcontracted by the State Office of Rural Health to help facilitate the Medicare Beneficiary Quality Improvement Project, or the MBQIP program. And our presenter today on our monthly webinars, as always, is Kerry Dunning. And so at this time, I will turn it over to Kerry.
Thank you, Becky. I hope everybody's doing well today. So what you see are 5 questions that I've been asked recently. So I'm going to go through those. And then I'm also going to go over some things that have just come out. Actually, one item was dropped yesterday by CMS. If you're even trying to keep up with the CMS changes, I think it was a 40-page document yesterday, and last week on the 8th, it was a 172-page document. So, and they come out with other things at that point. So it's really a whirlwind trying to keep up with changes. And as you know from being critical access, that the swing beds aren't always mentioned in these documents, so we have to kind of go through the weeds figuring out how to translate some of these. So we're going to go one by one through these and then the new items. So let me start right off with the topic of the day, which is facilities that are trying to get a negative swab before they admit to a swing bed. I actually just misspelled swing bed, sorry, on that. And I'm gonna suggest a prudent approach. Certainly we can base it on what's going on in skilled nursing, and certainly you can base it on what Indiana's asking you to do, and certainly you can base it on your hospital policy. But really the standard that we have been using across the industry, I'm getting some feedback, guys, from somebody. And Autumn smiles at me. So the 14-day isolation is the best way to do it. Is when you're admitting a swing bed patient, most of you have what I'll call private rooms, but you don't have 2 beds in a room. Really, they should be in isolation during that time period unless they discharge earlier. Then obviously up to the day of discharge or through the day of discharge would be better. So they cannot be cohorted when they're coming in. And this is really coming from several things. As I said, I'm going to kind of try and do prudent and common sense. Right now, about 1/3 of the tests are false negatives. That's a pretty sizable amount that even if you've got a negative swab, it may not be something that you could use for the, and I guess what we're seeing even out of the White House. And a day-to-day, they could have negative, 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 and the next day it's positive. So please try and think about just doing a 14-day isolation, which is what the nursing homes are required to do. And then in Swingbed, as far as who you can admit, you can admit COVID-19 patients or not. You can admit non-COVID patients or not. I know there is Indiana facility that certainly had COVID in acute, was probably going to do COVID in swing. It is a matter of what is going on in your immediate area. It's also a discussion for you to have with your referring hospitals, or in the case of several of you, with your systems, where they may need you to take one type of patient or another. Most swing beds are trying to take one or the other. They're trying to be all COVID or all non-COVID, because we're not supposed to be mixing the patients. If you have a physical setup in your facility where you can put COVID patients that are swing down one hall and non-COVID down another, that might work. You're going to have to make that determination. There are some notices from CMS in the last month that have said they don't want the swing beds intermixed with acute. In other words, if we have been using a system where we have left a patient in their room in our non-COVID life because it was easier to leave them there, which, by the way, was one of the original intents of the swing bed program, but now they're not acute level. They really want those populations separate. Obviously, they want COVID and non-COVID swing patients separated. And there is more than one document that has come from CMS asking that staff be assigned to specific rooms or specific patients. So even if you have a hallway full of COVID or non-COVID, that staff, and that means all the staff that might take care of those patients, are the same team dealing with the same 4 rooms, 6 rooms, whatever you guys decide is appropriate staffing. And then the next 6 rooms might be another set of staff. You're going to have to work out the staffing internally, but those are the general rules that have been set out by CMS in more than one document at this point. The other thing you have to consider is nursing homes are shutting down admissions. I am one that actually, I probably will get a visit from the tax man next year, but I made a recommendation to CMS right away when they were saying on March 13th that they expected the nursing homes to take admissions. The problem they have is they have an extraordinarily vulnerable population, which we're now seeing. And so many of them have decided not to take new admissions. They probably should take return of residents from you if they're, you have those type of patients in your swing bed program. But again, they're gonna really be shutting down admissions. And as of last Friday, they are required also to report to NHSN, which is probably your hospital is already doing, which, as you know, is part of the CDC. It's also in response to the federal government trying to figure out what's going on in long-term care. And to give you an example of why the nursing homes are now reacting so strongly, there is a list that was put out yesterday of the top 10 counties that have COVID, per capita rates of COVID in the country. The number 1 county was not New York, wasn't California, wasn't New Orleans, wasn't Detroit, wasn't the state of Washington. It was a small county in the state of Georgia. In fact, 3 of the top 10 counties with the most COVID cases in the country are in Georgia and rural health. And so what happens is when you see that kind of clustering going on, they really can't take admissions. We have nursing homes, again, I've got clients in Georgia, I've got clients in different states that have deaths in their nursing homes. I've got clients that I have one facility that I don't know how they've pulled it off. They have 0 COVID among their residents, but they have 14 staff members that are out that have tested positive. So I think all of them have tested positive. A couple of them were presumptive the other day. So there is a real mix. And as you know, once it gets in a population like that, no matter how much they're shutting down because of staff going in and out and other reasons, it's really, really hard to control. So what I'm getting at is that even if you don't have a nursing home in your system or around you that you team up with, the fact is there's going to be a need for putting patients at a skilled level of care. And that's where your swing beds can come into use. At this point, as long as you are an emergency, under the emergency, which we are, and you have COVID pretty active, which Indiana does, then you can expand your beds, and we'll talk about that if that need arises for you to do that. But that's where I'm going to go back and say, rather than a negative swab, I would rather see you use the 14 days of isolation on anyone coming into your facility. Another question I got last week or this week, I can't remember at this point, was on whether you were required to give the pneumonia vaccine. So I'm going to defer to 3 layers here on this. One is, you already know that it's one of the most severe infections we can get, particularly with the elderly, and it leads to other infections or causes other infections. So I went back to some basic mandates. So first is the Advisory Committee on Immunization Practices that CDC uses to set their standards. Set this just a few months ago. If you probably remember the discussion of whether that we should be using 13 or 23, and it came out a couple months ago about the 23 should be used on all adults 65 and older. And just in the last week, they've changed that advisory. I don't have the new one, but if you look up ACIP and you can see it, it has changed from all adults over 65 to the suggestion that that should be referred to their primary physician to make that decision of whether they should receive the dose or not. So I have it in blue there because it's just changed. And then in the nursing homes, basically we have to offer it to everybody in a nursing home, whether it's given or not, goes down to some preferences. There is a grid that shows all the states and what they're doing, and it's whether they are 65 plus, whether they have comorbidities, whether they have religious objections. And there's a category in the document that I hadn't seen before, which is philosophical differences with it. So there are reasons why people are not getting the vaccines. And I have there the information. It is on the MDS. It is required that it's asked. So again, that's nursing homes. And then you come down to the mandates. And what I'm going to tell you is you really need to work with the state of Indiana. The last document I can find from Indiana, the only requirement for pneumonia vaccines is for anyone in a veteran's home. It does not have any requirement for long-term care or nursing homes either, so or skilled facilities either. So it's going to be up to what your practice is and what your policies are on it. I will tell you there are 29 states now that have requirements for patients mandating it, and there are 6 that have a mandate for healthcare workers of different types and different settings. So I'm going to defer to that, but I'm going to suggest if they haven't had it, what the nursing homes must do, if that's the standard we're going to go by for now, is at least offer it to a patient. So I would look at your hospital policy, and I would check with the state of Indiana.
Kerry, can we pause there for just a minute?
Yep.
Okay. We did have a question came in, and before we got on to other topics, just wanted to be able to address it. It's Andrea at Community Hospital of Bremen. And the statement for not to intermix swing beds with acute, is this just during COVID or going forward, we need to have separate identified rooms? That defeats the ability to have observation, acute, or swing beds. Just questioning. Did we lose you, Kerry?
I've been unmuted. Autumn's taking care of me.
Okay.
It's under the emergency declaration. They're saying that they need to be separated, and we don't know how long that's going to last at this point. I suspect even when the emergency declaration ends, we will have COVID in our world. It's not going away. And I hesitate to be prescient and try and decide what they'll do with that regulation. I'm hoping they leave it back in the hands of those of you that are on the ground and you know the layout, physical layout of your facility, you know your staffing ratios and that sort of thing. But for right now, the recommendation is that they are separated and that you try and keep the staff related to one set of rooms or the other, but under the emergency declaration. So when that ends, then we're going to be scrambling again to try and get answers. Does that help, Becky?
I believe so, yes, yes. And Andrea, if that doesn't clear that up for you, why, let us know. You're welcome to unmute your line if you like. And you can unmute your lines by clicking on underneath the participant bar, the red phone next to your name. So anyone's welcome to unmute at any time. Okay, go ahead, Kerry.
Thank you. As far as keeping up with the regulations right now, the baseline for you always, and I think we've talked about this enough, it's the State Operations Manual, Appendix W if you're critical access. It's Appendix A. It used to be Appendix T, but it's now Appendix A if you happen to be a PPS Swingbed program. And so that's your conditions of participation. Those are the rules that they follow along, at least mirror a lot of the nursing home rules. The value you have is what they have in Appendix W for critical access, is a much shorter list of requirements than what nursing homes have. We've talked about the fact that nursing homes are the most regulated industry in the U.S., and their regulations go on for pages and pages. So I always will ask you to defer to the State Operations Manual. And the value of the State Operations Manual also is it's really the guidance to surveyors for your state and federal surveyors. So what you find in there, surveyors are going to be looking for or asking about. So it's, again, a good process for you to have. We are going to have surveys. We were having surveys pre-COVID in swing beds. I suspect with the nursing home issues going on, I have a client that's had 6 deaths of nursing home residents. They're expecting state to walk in anytime. So I think they're going to have to prioritize those who have had higher numbers of COVID patients and or higher deaths and or higher staff members out that were at least presumptively positive. They will probably center in on those numbers. But that if that is something that you are taking COVID patients, you could be on that short list. So again, State Operations Manual, Appendix W. Obviously the CDC is one of the places, and I want to repeat a rule here in case you haven't heard it. It is in the skilled rules in general, but it goes beyond even skilled. But what it says is you should notify the state or your local health department. Most people in most states, again, I'll ask you to defer to Indiana, are required to report it to the local, who then reports it to the state, or they're required to report it to the local and the state. And one of the rules is, within 24 hours, if you have severe respiratory infection causing hospitalization or death, if you have a cluster which is defined as 3 or more residents and healthcare workers combined, so that's your healthcare staff and residents, in this case, put patients in there. But if it's 3 or more, then you have to notify the local and and state health departments. And if you have anyone that is suspected or confirmed COVID-19, you have to do local and state. I have no doubt all of you are probably already involved in that process. I have also put the CDC beginning one of the opening pages to get into all the COVID information, and this particular one I have tagged on the end of it, the long-term care strategies. It has been massive. It's been week after week after week of things, and I've been trying to pass on through Becky a short version. In fact, I've got to do one for the one that was released yesterday, but I'm going to give you a heads up on some of that today. But a short version of it so you can at least see what's being said and see if it applies to you, or if it raises a question about what your hospital policy is, or if you don't have a hospital policy, then that's something you need to address. I have written 4 policies in the last 3 weeks on topics I've never written about in my entire career, and I'm old. I've been in the business 35 years or something. I mean, there's absolutely no reason in past history, even with our other outbreaks of pandemics or epidemics in this country, that we've had to have them. So we've got a lot of changes going on. Obviously, you can go use Indiana. I put the address down there that you probably know well. and certainly Becky is working with them very closely to keep you updated as things happen. So they have posted, I think, on the Indiana site some of the new things that came out. On May 11th was the last one I saw on that site, but this other one just came out yesterday, so I'm sure today, tomorrow, they're going to be posting it because it has the new directives and new waivers for nursing homes. We cannot draw a straight line between nursing homes and a critical access swing bed program. You are part of a hospital. So your hospital should be telling you what rules and reporting standards they're going by for what the hospital has. It is a dotted line between skilled nursing and the swing bed program because they're under the same huge umbrella of long-term care and skilled nursing regulations. So I have sent to Becky today, there is a new attached list of FTag changes that have changed. We now have some COVID-specific FTags and some other things that have been changed. You will see it if you print it out. If you just look at it on the screen, you're going to see a number of them that are in red. They have changed, and that can mean that 2 words changed or 20 words changed or 20 paragraphs changed. So you might want to look through them if there are things that you think apply to you, because you remember you're going to be surveyed by a state or federal surveyor that's used to FTags. And F is federal. They stand for federal tags. I also sent Becky the survey updates. It is a document that shows you page by page a certain standard that has been there and what they changed under that. That may help you limit you having to read through 1,000 things to catch up to see if there's something that now requires you to change one of your policies or at least review internally. So you'll have that information. All right. I was asked a question about a pharmacist review, and I'm going to tell you, again, this is one of those prudent things that you need to do. I have recommended to Indiana and the other state rural health associations that I work with that I think it is helpful to everybody involved if medications are reviewed when you're admitting a new patient to swing bed. It's one of the stops or the pauses that we have in the healthcare system where, acute has 96 hours, you have post-acute has only so many hours home health can be in, only so many visits outpatient can have. In swing, we have 5, 8, 10, 14, 21 days, whatever it is, where we have time to stop and look at the total medication list and make sure it's up to date. So the 3 stages that we normally go through on this, the first one is there is a Pharmacy Practice Act, and so your pharmacists are under some directives they have to follow for their licensing. And part of that is that they need to make sure that when they are dispensing, that everything that is being given to that patient is safe to present to that patient and have the patient take. So there is a first level of that. And they're the ones that usually do the comprehensive drug regimen reviews in nursing homes and in most of the swing bed programs I'm working with. Now, the difference between nursing homes is they usually use a consultant pharmacist. They don't have a pharmacist on site. In the swing bed programs or skilled units, we typically are using a pharmacist from your hospital, or again, if you're in a system, it may be a system pharmacist. The second part of this is that drug regimen review is mandated on the MDS now in 2 different directions. And it was updated again on January 13th, which says they're after resident safety by identifying and addressing potential and actual clinical significant medication issues. So just so you know, under skilled nursing rules, which remember you're under that umbrella, there are 7 areas of review going on with medications in the U.S. right now. I suspect COVID will be higher than this, but this has been a key point they have been looking at. One is polypharmacy, and that's the one where the drug regimen review has the most value when we're talking about a swing bed, is these guys coming on 15, 17, and 19, and 21 meds. Is there a way we can help them reduce meds? 1, so the medications work properly. 2, so they can take them properly. If we have, meds in the morning with breakfast and 1 at 10 a.m. and 1 with noon and 1 at 2 and 4 and dinner and bedtime, people are taking the wrong meds or missing times. So that's the second part of that. And the third of it, that we have a chance with the Swingbed program to help your community members, which is those meds cost a lot of money. And we have plenty of examples, and I'm sure you can think of one that, that you've seen recently where people aren't filling them, or refilling their prescriptions because they can't afford them, or they're taking a drug on Tuesday and Thursday they should be taking every night, and taking another drug on Monday and Wednesday. So it is a helpful situation. So the MDS has 2, actually, drug regimen reviews that have to be completed, not just 1, 2 different ones. So one of the questions is, was there a drug review? But the second one is one that you need to pay attention to, which was the physician, and in this case, physician is going to be your PCP, notified by midnight of the next day. You do not have to complete the MDS in the critical access, so don't take this as a literal statement. But as you know, I firmly believe, and I've actually had CMS say this lately to me, that's where they have Medicare intent for skilled level care. So pay attention to that. And then the third thing that I have put down there is it's actually a CMS handout on how to do drug regimen reviews and work with pharmacists. It's the actual CMS handout that might be helpful for you guys to read through in all of your spare time, or at least provide it to your pharmacists. All right,
Kerry, if we could just pause there for a minute. Someone who's new to Swingbed, as in the coordinator role, wasn't familiar with FTags, and I know that we have others that are newer in their roles too. Could you just go into a little more detail about the FTags? Certainly.
One, you're going to get a list when Becky has time to forward all this, because I didn't get her this whole package until late this morning. FTag is a federal tag. There is a big manual out there. It's called, if you've been around skilled nursing at all, it's called the Red Book in most of the world. In the Midwest, sometimes they call it the Watermelon Book, but it's thick enough you can put it on a chair and sit a toddler on it. It's that thick, to be able to get above the table. But it is the guidance to the surveyors on every single topic that could come up in a nursing home. So when they come in to survey any kind of skilled level of care, which a Swingbed is, skilled level, they have these questions there to ask. They have these guidance comments. You can buy the book if you want a heads up on it, but what it is they come in looking for certain standards. If they feel you have not met those standards, let's take an example right now, because one of the hot topics is infection prevention, not just infection control, but infection prevention. That's going to be highly reviewed, I think, for the next couple of years, obviously. And infection prevention is time with your Swingbed patients as well as your acute patients. There are standards in there that say, here's what we want you, this is the minimum we expect you to meet this standard. So Washington, Kirkland, the nursing home in Kirkland, one of the major citations they had was that they did not meet the infection control and the infection prevention standards set by CMS. So when they don't meet that standard, so if we use Kirkland, they were cited, then there were FTags, federal tags, that were assigned to that. And those federal tags immediately put a facility on watch that they are to correct whatever the FTag has cited, and there is a written description by the surveyor that you get, and they have to correct that, and they have to correct it quickly. There will be a repeat survey if there are any FTags handed out, and on that repeat set, they expect you to have corrected everything that they found. If you don't, then you go into a sizable fine per day until it is corrected. Now, that's the nursing home experience. We're just getting into Swingbed reviews, and the only thing that I've heard in Indiana, Illinois, and Iowa, which is sort of a region, are facilities getting tagged for their activities programs. And so they'll have an FTag, but because that's really the only area, there have not been fines associated with that. So when you look at the FTag list, you'll see, again, how extensively regulated the skilled and long-term care industry is, and there are topics under there, anywhere from administration to medications to nursing services and so forth. So it would behoove you just to go through that list and look at it. I would be paying attention to anything around infection prevention and infection control right now, and even anything related to that, because if you're going to get surveyed the next year, that's going to be one of the first things they'll be looking at. So does that help, Becky?
Yes, thank you.
You're welcome. All right, we had a new document that came out yesterday. I'm going to give you 3 updates. I think I limited it to 3. So what was nice about this document is the first time where the things they wrote were specific to that they said they were new since a 430 release, which helps us because we've had to read through 177 pages. This one was 40. Trying to see if they stuck a word in here or there. So this one says new since 430. And this is your swing beds and the fact that you can expand your beds, and they have very specific qualifiers for waivers. That you cannot be using your swing beds for acute level of care. That has been a standard. We're a post-acute level, a skilled level, and I've said before around many of you, you might as well be the nursing home 10 miles down the road with skilled patients. So we have to be careful with physicians not doing acute level care or ordering acute level care type of testing when they have been discharged from acute and put into a swing bed. I don't think we're going to have as much trouble with that, and right now while we're under the emergency declaration, mainly because they have released you from the 96-hour rule, and they have expanded where you can expand the total number of beds you're using. But just know that very clearly and make sure the documentation doesn't show anything that's skilled. Then you have to meet all the other conditions of participation, and the reg is there. But I want you to read this third qualifier because this is something someone in your system should know well, and you should be getting information from that person or group of people, which either has to be consistent with the state's emergency preparedness plan or the pandemic plan. You should also have a facility emergency preparedness plan and pandemic plan, and I will tell you right now, that will be the other thing surveyors will be reviewing word for word, is what that emergency preparedness or pandemic plan is. Usually the pandemic has been a subset of emergency preparedness. Like I live in Florida, so ours includes tornadoes and hurricanes and earthquakes and flooding and then a pandemic. Oh, nuclear power plants too. So we normally have those things in my part of the world. Yours will have some of that. You probably won't have the hurricane on that list. But your plan, what you want to do is whoever's in charge of emergency preparedness in your facility or in your system, you want to make sure that they have addressed anything that might be specific to your swing bed. And one of the areas is if we had to shut down a hospital like we do when a hurricane comes through and causes damage, where would we transfer those transfer agreements, but where would we transfer skilled patients? And probably that would be to a skilled nursing facility. So just double check that piece of it. But you should be aware what's in that emergency preparedness, and hopefully all your systems have been talking about that. The next thing is you do have to call your MAC, which is a billing entity. It's the Medicare Administrative Contractor, and there's a hotline, and you have to let them know that you're adding swing bed services or adding swing bed beds or total beds, either way, and there is an order of there for you to go through. So some of it is that you've exhausted other options. Again, the skilled nursing facilities may not be willing to take COVID or may be filled because they're also having to isolate. So where they've had 2 people in a room, they have a lot of rooms where they have 1 person only. If there's presumptive or they've returned with COVID, than any of the other eligibility pieces there. So the idea is to discharge the extra patients as soon as is reasonable, and if a swing bed becomes available, a SNF bed becomes available, to be able to start using the skilled beds in your area again, or the emergency declaration ends. Which again, I can't tell when it's going to end because I don't know that we have an end to COVID, but we're going to have an end to the emergency declaration at some point. So that's a new release as of yesterday. The other thing that was interesting that came out yesterday is for OT, PT, and speech. And the comprehensive assessment, this allows for any rehabilitation professional to perform the initial and comprehensive assessment for all patients. We have had some of that in the past because state law has allowed it, but you might pass this on to your therapy department and see how they would like to address it, or they may already be under a state law that allows them to do that. So that's a second thing that came out. And then the third one is on life safety codes, again, which are always part of surveys. And it's talking about the requirements they had for alcohol-based hand rub dispensers because of the increased need for them. There have been some that were not allowed because they were considered flammable. So they have reworded some of this and looking at where you're going to be storing bulk containers and other things within your system. And then they have said you can call off fire drills for now. Doesn't make much sense when we have social distancing to have everybody, you know, going out of the building at the same time. And then the third one is construction. So that's the barriers and walls that may have been taken down that we're now trying to keep people separated. So, Becky, that's about as fast as I can talk today and kind of get through all the pieces of it.
Well, thank you so much, Kerry, and we're really out of time for today. But again, please reach out if you have questions, and Kerry works real hard with me to make sure that you get a complete and full answer. We'll be having the regional meetings in June. So if you need an invitation, the original invitations were sent to those that were originally registered for the March meeting. So please let me know if you still need an invitation, but any hospital is welcome to invite others to those regional sessions. It will be small group sessions, so we'll get a lot of personal and private time with Kerry to ask your individual questions and kind of have a little mini audit of your program and go over some of these COVID impacts in more detail. So I thank you all for joining today, and just stay safe out there and let us know what your needs are. Thank you so much. Bye-bye.